I invite our President of Dance, Dr. L. Murugan sir, to give the welcome address.
Thank you, Dr. Rajesh Babu. Good evening and a warm welcome to all of you who are joining us for this meeting today. Special thanks to our two speakers for joining us to enlighten on this very important topic in neurosurgery. Please make use of the speakers to the maximum by clearing all your doubts at the end of the talks. Thanks to Rajesh Babu once again for coordinating these meetings on a regular basis. Thank you and welcome once again.
Okay. Now it is time for, first of all, I welcome our President, Dr. L. Murugan sir, and President-elect, Dr. Suresh Jayabalan sir, our Joint Secretary, Dr. Karthikeyan, and our Treasurer, Dr. Kodiswaran. Now we will invite our the first speaker of the day, Dr. K. Malcolm Jeyaraj sir, with the topic of intractable epilepsy. This session actually, now I invite Dr. K. Malcolm Jeyaraj sir to give his lecture. First introduction of Dr. K. Malcolm Jeyaraj sir. Malcolm Jeyaraj sir is the Senior Assistant Professor of Neurology, Stanley Medical College, Chennai. Qualified MD General Medicine from Tirunelveli Medical College and DM Neurology from Stanley Medical College, Chennai, and PDF Epilepsy in Sri Chitra Tirunal Trivandrum. Areas of interest are evaluation of drug refractory epilepsy patients, video EEG, and epilepsy surgery, intraoperative neuromonitoring. Sir, I invite Malcolm Jeyaraj sir to give his talk on the intractable epilepsy. Welcome you, sir.
Thank you very much, sir, for the kind introduction. A very good evening to senior professors, colleagues, and friends. A very good evening to all. This evening, I would like to share my thoughts on intractable epilepsy. Okay, sir. The outline of my today's talk will be on the definition of drug refractory epilepsy, the problems of refractory epilepsy, the predictors of refractoriness, mechanisms of drug refractory epilepsy, and approach to refractory epilepsy. The working definition of drug refractory epilepsy can be said to be a failure to achieve sustained seizure freedom after an informative trial of two adequately used and tolerated antihypnotic. Okay, sir. The fate of a newly diagnosed epilepsy, as studied by Dr. Brody, which is one of the landmark papers, wherein they studied nearly 780 patients with a newly diagnosed epilepsy and followed them for a very long period of time. And they found that nearly 60% remit, and of which 30% respond immediately, while 5% relapse. So naturally, around the non-responders or refractory patients are around 40% of any newly diagnosed epilepsy. Now, what are the problems that a person with the refractory epilepsy encounters are educational and occupational underachievements, restricted lifestyle, cognitive deterioration, psychosocial dysfunction, physical injuries from seizure-related falls, frequent hospital admissions, disturbed family life, poor quality of life, and increased morbidity and mortality. Now, the comparison of a quality of life with seizures in patients with hypertension, diabetes, and heart disease were compared, and it's a T-score, and it shows that persons with drug refractory epilepsy have the poorest quality of life. Now, what really contributes to the refractoriness, or what are the risk factors for refractoriness? I will go one by one. The first is the epilepsy syndrome. As we all know, the epilepsy is a very heterogeneous entity, and there are patients who fall into primarily three categories, we can say. One is the idiopathic syndrome, idiopathic epilepsy syndromes, and the others are symptomatic and cryptogenic in the older classification. So the SEMA has actually followed from the older classification and found that Those who have idiopathic generalized epilepsy, the prototype is the juvenile myoclonic epilepsy. They rarely become refractory. But patients with symptomatic and cryptogenic, especially with lesions like hippocampal sclerosis, they have the greatest possibility of refractory epilepsy. Now, with regard to epilepsy syndrome, once again, when it was followed over several months, nearly for around 4 years, they found that idiopathic generalized epilepsy really did well, whereas the non-idiopathic group had a high risk of refractoriness. The next important factor that causes the refractoriness is the type of the lesion. And in that, they found that the patients with the dual pathology and hippocampal sclerosis and focal cortical dysplasias had a higher chance of becoming refractory than patients with post-stroke vascular malformation or tumors. Now, what are the other predictors or other factors that can be associated with refractoriness? Are an early age of onset, the presence of a symptomatic epilepsy, an abnormal EEG, presence of history of febrile seizure, an abnormal neurological image, presence of mental retardation, neurological abnormality, status epilepticus, and psychiatric comorbidities are other predictors of refractoriness. One other study by Berg also said that the higher seizure frequency may mean more refractoriness. Okay. Now, we have seen about the problems the patient with the refractory epilepsy undergoes and what are all the risk factors. Now, we'll go into what really causes refractoriness. I'll try to go one by one. The first issue is these are all, we have to understand, these are all hypotheses. They are all postulates. And we do not know for sure whether they are the reason. And each person can have one reason or many reasons put together. One of the commonly ascribed reasons are alteration of drug targets in the brain. That when the patient, for example, you keep on using carbamazepine in a patient, and there is a use-dependent block of voltage-gated sodium channels in dentate granule cells, which leads to drug resistance. This is one of the postulates. The other well talked about postulate, but I mean, down the years, not much is being talked about, is the resistance is due to inadequate penetration of anti-seizure drug across the blood-brain barrier due to increased expression of efflux transporters. That is, a patient who acquires the ABCB1 gene, the ABCB1 gene, the product of which is peak glycoprotein. When that is there in the blood-brain barrier, the ASDs are not able to adequately penetrate into the brain. The other postulate is alteration of pharmacokinetics in periphery. For example, an overexpression of efflux transporters in intestine. The same PGP protein, the subtherapeutic means that the drug that is swallowed is not adequately absorbed. The other issue could be a cytochrome P450 induced increased metabolism. The fourth postulate is the neural network hypothesis. Epilepsy is associated, epilepsy per se, when the patient starts seizing, recurrently seizing, they can have associated structural alterations in the form of neurodegeneration, axonal sprouting, synaptic reorganization, neurogenesis, and finally gliosis. The classic case that is used to explain is a patient with hippocampal sclerosis associated drug resistance. The moment you remove the hippocampal sclerosis through a hippocampectomy, then the patient becomes a drug responder. And this amply justifies the neural network hypothesis. The next hypothesis is the intrinsic severity hypothesis. That is, the more severe the disease, the less likely the response to anti-seizure density. And this depends upon the seizure frequency and density, which could be seen either at the onset or in the course of the illness. And it is an intrinsic property of the epilepsy. The one new kid of the block, of which a lot of studies are being done, are the gene variant hypothesis. And the classic gene that I'm going to talk about today is the SCN1A gene. And we know that there's the single nucleotide polymorphisms in a single gene can be a conformation, could be a binding of an encoded protein, or the stability of the transcribed mRNA. And this could lead to a variety of manifestations and thereby lead to drug resistance. And we all know that in SCN1A gene also, there could be a gain of mutation as well as a loss of gain of function as well as a loss of function. For example, if there is a loss of function, then you may not be able to give a sodium channel blocker. But in an SCN, that's a classic Brave. In a SCN1A where there's a gain of function, you may have to give in a sodium channel blocker. And one very important hypothesis is neuroinflammation and blood-brain barrier dysfunction as potential mechanisms, which is the last among the hypotheses. And we actually potentially we may see such a hypothesis in patients with functions like autoimmune encephalitis, especially the VGKC antibodies. The hypothesis they are trying to convey is there is an astrocytic dysfunction that leads to oxidative stress, angiogenesis, and decrease in tight junctions, induction of cytokines, increased PGP, and increase in the inflammatory mediators. Okay. So after looking at what are all the possible hypotheses, we have to understand that in a given patient, there may be one hypothesis working or multiple hypotheses working. So when a patient comes to us with failure, the first drug, what is that we have to check? The first thing that we have to check is whether the patient is on the correct anti-epileptic drug. The second thing is whether he has taken an adequate dosage. Third, whether he takes an adequate sleep and rest, timely food, nutrition, and there is no stress and no provoking factors like alcohol. The other seizure triggers could be fever, illness, trauma, stress, lack of sleep, fasting, fluid electrolyte balance like hyponatremia or hypoglycemia, the hormonal issues, alcohol, and drugs. So, if my first drug fails, what do I have to do? The first thing that you have to understand is seizure disorder is a highly heterogeneous entity. So each seizure or each seizure syndrome or each epilepsy syndrome has to be treated differently. So for example, if a patient comes to us with an idiopathic generalized epilepsy syndrome, or for example, a juvenile myoclonic epilepsy syndrome, which is a prototype, we start the patient on eptoin or carbamazepine, which is a sodium channel blocker. It will aggravate the epilepsy syndrome in that individual. It can produce an aggravation of myoclonic status, atonic, and in some other IG syndromes, it can also produce absence status. The next thing is drugs like benzodiazepines may provoke, it's not that they frequently provoke, may provoke tonic seizures or tonic status epilepticus when given intravenously in LGS syndromes. So first step, I would say, when a patient comes to us with seizure, try to identify the epilepsy syndrome. Once you have identified the epilepsy syndrome, kindly consider the age, the gender, the other comorbid issues, and other psychiatric issues that coexist in the patient. And then choose the appropriate drug. Then choose the appropriate drug in the appropriate dosage. And if he fails, you can try two things. One, you do a sequential monotherapy, or you do an add-on therapy. The next thing, important thing, when the patient fails with the drug and comes with an enormously increased frequency of seizures, you have to rule out the coexistent pseudo seizures, and nearly 20 to 30% of pseudo seizures may exist in patients with epilepsy. So, as I was talking earlier, the most important thing is rational polytherapy. You have to consider the mechanism of actions of AEDs, the pharmacokinetic interactions of new and old AEDs, the adverse effects of old and new AEDs, and put them in proper combination. Are there any specific combinations that are useful? The good combinations would be something like valproate and clonazepam, carbamazepine and clobazam. But the well-studied one is valproate and lamotrigine, which has got a very synergistic effect. The other drugs that could be combined are phenytoin, the age-old phenytoin and phenobarbital, and lamotrigine and topiramate. Some bad combinations could be you are combining two sodium channel blockers, which may not be a very good combination, like phenytoin and carbamazepine. Similarly, two GABA drugs like phenobarbital and clobazam could also be poor combinations. So when I encounter a patient with medically refractory epilepsy, when, how long, and how much? So failure of adequate trials of two tolerated and appropriately chosen and used AD schedules, whether as monotherapies or in combination to achieve seizure freedom. So when this fails, we call this a possibility of medically refractory epilepsy. But we have to understand that their compliance should have been good, the functionality and the social role also the patient plays. So when the patient fails, it is ideally that this patient is seen by a team which consists of the epileptologist, the neurosurgeon, the neuroanesthetist, the technologist, the EEG technologist, the neuroradiologist, the psychologist, and neuropathologist with a battery of specialized investigations like video EEG, epilepsy protocol MRA, neuropsychological evaluation, electrocorticography, and PET and SPECT imaging. Now, before I go into the surgical aspect of the drug refractory epilepsy, I would like to touch upon that we are in an era of precision medicine. That is, as I had already told you, we have to understand what particular epilepsy syndrome. That was our thought earlier, and what is the age, gender, and then choose the anti-epileptic. But now we see not only it's an epilepsy syndrome, but we have to type what particular genetic abnormality in certain given cases. This comes especially in patients who present to us with developmental and epileptic encephalopathy. We call the DEE syndromes in early childhood. So we have to try to understand whether they belong to SCN1 mutation or SCN2A or SCN8A or whether they belong to GRIN2A. Why? Because this is a very, very important point. Because a drug that can be given for one mutation may not be useful in another mutation. For example, this SCN1A, the ideal drugs would be something like cannabidiol, which is going to enter into the Indian market. In SCN2A, we see whether there is a gain of function or a loss of function. And if there is a gain of function, the ideal drug would be phenytoin. Whereas in an SCN1A, if you are going to give a phenytoin, it could lead to a status. In SCN8A also, we look at whether it's a gain of function or a loss of function. And if there is a gain of function, we try to push in a drug like a sodium channel blocker like phenytoin or carbamazepine. Similarly, in patients with tuberous sclerosis, one of the potentially beneficial therapy would be everolimus. And if it is a GRIN2A mutation, the ideal drug would be a memantine. So we try to understand from this busy slide, that it depends on the particular each genetic syndrome, not only each genetic syndrome could be having a gain of function or a loss of function. And depending on whether it's a gain of function or a loss of function, especially with respect to SCN mutations, we may have to choose an appropriate drug. Okay. Now, apart from medically refractory epilepsies, which are genetically mediated, now we look at the surgical aspects of it. So, in a patient with refractory epilepsy, is surgery for epilepsy effective? This was studied in a randomized controlled trial in patients with temporal lobe epilepsy, and Professor Samuel VEEG from Canada has clearly shown to us that the patients in the surgical arm were nearly 58% seizure free, while those in the medical arm were only 8% seizure free. So there is a huge difference between the surgical and the medical arm in patients with refractory epilepsy. So there is no doubt that when a patient is having a refractory and a clear-cut epileptogenic substrate, and there is a good clinical, electrographic, and radiologic only provided he has got a clinical, electrical, radiological correlation, then we can proceed. The next thing is coming to early surgery versus medical therapy in TLE. Nearly 11 out of 15 in patients, Engel followed and found that nearly 11 of the 15 patients were seizure free at 2 years, whereas none of the patients were seizure free at in the medical arm were free. In children, which has been studied in India by Sarat Chandra, they found that patients who had underwent surgery were nearly 77% seizure free, whereas those in the medical arm were only 7% seizure free. Plus, the added benefits were improved cognition and quality of life. So when we decide that the patient is having a surgically remediable epilepsy syndrome, how do we go about is you take a complete history and examination. The most important thing is you rule out a progressive neurological disease. You undertake the patient with a long-term video EEG monitoring. You do an MRI, do a neuropsychological assessment. Depending on the given case, we may need, and if not all cases, we may need an fMRI, a SPECT, a PET, or MEG, or invasive studies. Then finally, going for clinical electrical imaging concordance. Sorry. What are the ideal substrates of surgically remediable epilepsy syndromes are hippocampal sclerosis, cortical dysplasia, tumors, gliosis, especially low-grade gliomas, traumatic or ischemic, vascular malformations, Sturge-Weaver syndrome, porencephalic cyst, Rasmussen's encephalitis, and hemimegalencephaly. So, I'm giving a brief overview. So, we ask the question, is this patient surgically remediable? And then we look at once surgically remediable, then we classify them as temporal lobe epilepsy versus extratemporal or a hemispheric pathology. If it is going to be a temporal lobe epilepsy, then we see whether it's an MTS or other lesions. And depending on them, you proceed with the appropriate surgery. I'm not going to touch much on the surgical aspect as Dr. Rohit will be talking about it. If it is an extratemporal epilepsy, then we decide whether it's going to be a lesionectomy versus a lobar or a multilobar resection. And if it is a hemispheric pathology, for example, a classical case like a Rasmussen's encephalitis, we may go in for a hemispherotomy. Now, some of the patients who may not benefit much from curative surgery, so they may need only a disconnective or palliative surgery, especially when the patient has got severe drop attacks, may proceed with a callosotomy. And in young children where there is no respite to any kind of medications, and you have bilateral pathologies or diffuse pathologies, we may have to think of multiple subpile transactions, VNS, ketogenic diet, or RNS. Of course, the new kid of the block is stereo EEGs. So here I'm giving you a flow chart. So when a patient comes to us with a diagnosis of epilepsy, the diagnosis of epilepsy is based on at least 2 unprobed seizures 24 hours apart, or a 1 unprobed seizure with an MRI and an EEG abnormality, or a diagnosis of epilepsy syndrome. You start the patient on a drug, just monitor the side effects and drug-drug interactions. If seizure continues, going for a rational sequential monotherapy or an add-on. Then if still he has a recurrence of seizures, maybe he has to be evaluated by a comprehensive epilepsy program center. And there we try to first rule out the possibility of pseudo seizures in this patient. And once pseudo seizures are ruled out, then we take them up, as I have already elucidated, into the same panel. Here, I would like to now discuss a prototype case which we had done in our institution in Stanley. Here is a 9-year-old boy with a normal birth and no antecedents. He had recurrent seizures since 6 years of age. The frequency of seizures were around 3 to 4 per day with clustering, and hence he dropped out of school for 1 year when he came to us. He was a right-handed individual. There were no neuroperintis markers with a subtle right pronator drift. And this was the lesion that we found that in T2, there was a hyperintense lesion, which is just abutting the postcentral gyrus, and T1 is hypointense. And this was the EEG that we did in the patient, and shows a clear-cut spikes, the centroparietal region. Yeah, we did a video EEG in this child, and we found that the patient had seizures involving there was a slow head drop, and there was focal jerking in the right upper limb, and the ictal electrography also showed a beta spike in wave discharge, which was emanating over the centroparietal region and following the same region. So there was a good clinico-electrical concordance in that the IEDs were from the spikes were from the centroparietal region. The ictal electrography also had a centroparietal origin, The seizures, clinical semiology also showed that it was a left hemispherical seizures, probably arising from the Rolandic strip. So we went ahead and did functional MRI, and this was the motor finger tapping that, and it showed that it was closely abutting the lesion. The sensory also showed that these red dots show that it is closely abutting, though they are not very classical actually. And the results given showed on right finger tapping, cortical activation was observed along the superior and lateral aspect of the left precentral gyrus. The lesion is posterior to the motor cortex. On right leg tapping, cortical activation was observed along the superior and medial aspect of the left precentral gyrus, and the lesion is indenting the lower limb motor area. On the functional MRI sensory, the paradigms are not very standardized. On right upper limb sensory activity, cortical activation was observed in the left post-central gyrus and along the anterior superior aspect of the lesion. So and we did a WADA also on the patient, which showed the motor cortex was lateralized to the left hemisphere. So now the dilemma for us was this patient had a lesion, and the functional area was very closely abutting the lesion. So we proceeded with the, I'm sorry, this also may not play, just try. So we went ahead with the awake craniotomy this time. So we went ahead with the awake craniotomy in this child, and we did an intraoperative electrocorticography which showed spiking just around the lesion. So we did a corticographic guided resection of the lesion, and this was the post-op CT brain of the child. And what came as histopathology was it was a DNET, Hook grade 1 parietal. Now, this child, which we did nearly in 2016, if I'm not wrong, is now a grown-up boy. And this is our new lab, VEEG lab in Stanley Medical College, and he's got absolutely no deficits, and he's been seizure-free for nearly 8 years, and is completely off anti-epileptic drugs. I thank the organizers for giving me this opportunity to talk on intractable epilepsy. And in summary, I would like to say that the newer modalities are giving us exciting opportunities to treat patients with intractable epilepsy, both medically in the form of genetic epilepsies as well as surgically. Thank you very much.
Now I invite Dr. B. Rohit sir to give his talk on Anteromedial temporal lobectomy. Before that, we will have an introduction. Dr. Rohit completed a MBBS from Stanley Medical College, Chennai, and MS General Surgery from Keelpop Medical College, and passed DNB General Surgery in 2006. Completed M.Ch Neurosurgery from Institute of Neurology, Madras Medical College, Chennai, in the year 2010. Work experience: worked as an assistant professor in Madras Medical College from 2010 to 2013. Working as a consultant neurosurgeon at Kovai Medical Center and Hospital since 2014. Has been doing epilepsy surgeries at KMCH since 2012. I invite Dr. Rohit sir to give his lecture.
Good evening, one and all. At the outset, I would like to thank TANS for this opportunity to talk on surgery in refractory epilepsy. Approximately 1/3 of patients with epilepsy fail to achieve adequate seizure control with anti-epileptic drugs or unable to tolerate the side effects. And a large body of evidence indicates that failure use of various anti-epileptic drugs, many patients are not able to tolerate the side effects and still continue to have seizures. Now, when medical therapy fails to control seizures, a comprehensive surgical evaluation is appropriate. And the most common and well-characterized focal epilepsy syndrome is mesial temporal lobe epilepsy. And for patients with intractable mesial temporal lobe epilepsy, an anterior temporal lobectomy and amygdala hippocampectomy offers the possibility of seizure freedom. From an electrical and clinical perspective, temporal lobe epilepsy can be divided into two different subtypes. One is the mesial temporal lobe epilepsy and the neocortical temporal lobe epilepsy. And the difference between, or the distinction between the subtypes is made on electrophysiology, pathophysiology, and also response to surgery. Now, hippocampal sclerosis or mesial temporal lobe sclerosis is the most frequent histopathology encountered in patients with drug-resistant temporal lobe epilepsy. Now, other causes for temporal lobe epilepsy include tumors, infections, cortical dysplasia, vascular malformations, and trauma. Now, the differential diagnosis for neocortical temporal lobe epilepsy is almost similar to mesial temporal lobe epilepsy, only with the only exception of hippocampal sclerosis. Now, going into the etiology of hippocampal sclerosis, this is quite a busy slide. The most common etiology that we see is complex febrile convulsions before the age of 5 years. And a subset of patients have dual pathology. About 15% of patients with other pathology also have mesial temporal sclerosis. It is not really clear which serves as a true epileptogenic focus, but generally resection of both foci yields the highest seizure freedom, as long as preoperative evaluation localizes to either of these foci. The kindling phenomenon has been implicated in causation of mesial temporal sclerosis. And in these patients, despite resection of extratemporal focus, mesial temporal sclerosis can continue to act as an autonomous source for seizure generation. Now, the pathological hallmark of hippocampal sclerosis is segmental pyramidal cell loss, which can affect any of these sectors of the hippocampus. The CA is cornu ammonis. The hippocampus has hippocampus proper along with the dentate gyrus and subiculum. Now, there's a classification by the International League Against Epilepsy on the hippocampal sclerosis subtypes. Now, the type 1 refers to severe neuronal loss and gliosis predominantly in CA1 and CA4 regions, compared to CA1 predominant loss in hippocampal sclerosis type 2. This classification is important because patients whose hippocampus has been resected on pathology have found to be having ILAE type 1 hippocampal sclerosis have had the best surgical outcomes so far. The other subtypes have so far been less studied, and the results are not as good as that we see in type 1. Now, going to the semiology in temporal lobe epilepsy, especially mesial, the commonest presentation is aura, which can either be autonomic, cognitive, or emotional. Autonomic, the most common, the one we see is abdominal aura, which is a hallmark sign of mesial temporal origin. It's seen in around 60% in temporal lobe epilepsy and about 20% in extratemporal. The limbic system seems to be involved in the abdominal aura, but abdominal aura is seen in both dominant, is probably due to stimulation of the visceral network involving the insula. The next common semiology is the hand-mouth automatism that we commonly see. It is due to involvement of amygdala and the anterior temporal region. The other triad is contralateral dystonic posturing of the upper extremity preferably. Now, there are other clues which helps us in localizing. One is postictal speech dysfunction, which obviously indicates lateralization of seizure to the dominant hemisphere. And a few red flags for the right temporal origin is deja. Another important emotional component is fear as an aura, which indicates involvement of the amygdala. Now, this clinical feature is important because in patients who present with fear during surgery, we need to be a little more radical in terms of resection of amygdala. That is one point. Next is evaluation of mesial temporal lobe epilepsy. The first step is obviously a scalp EEG. An awake or sleep deprived analysis is important as it helps to localize the epileptogenic focus. Now, many patients with mesial temporal lobe epilepsy, they show unilateral spikes on the anterior temporal region, unilateral intractable spikes. A few people have also reported lateralized short duration, less than 30 seconds discharge of about 5 Hz after the seizure onset to be associated with an ipsilateral mesial temporal lobe epilepsy. And the sensitivity of detecting an EEG abnormality increases by performing the test within 48 hours of a known seizure. Now, a critical evaluation for surgical candidacy involves inpatient admission and video EEG monitoring. Now, correlation between the seizure manifestation with interictal and ictal discharges helps us localize the epileptogenic focus. Provocative measures such as reduction of medicine, sleep deprivation, and hyperventilation can be used to induce epileptiform activity. In spite of all this, scalp EEG fails to lateralize the seizure focus in about 10 to 20%, and in another 10%, it can also be falsely localizing. And in these cases, when there is discordance between different tests, or we have a suspicion of multifocal epilepsy or a MRI negative temporal lobe epilepsy, we need to resort to invasive EEG. Now, from hippocampal depth electrodes, at times we see characteristic electrical activity, which includes periodic spiking activity from the hippocampus, followed by high voltage rhythms that last for up to 1 minute. Further down to imaging, now MRI is the standard diagnostic imaging modality for temporal lobe epilepsy. Now the ILA has laid down guidelines for MRI epilepsy protocol. It's called Harmonizing Neuroimaging of Epilepsy Structural Sequence, HARNESS. Basically, 3 sequences are required for mesial temporal epilepsy. One is high resolution T1, high resolution FLAIR, and high resolution T2. All coronal cuts perpendicular to the longitudinal axis of the hippocampus. Now, typical findings in mesial temporal lobe sclerosis are hippocampal atrophy and increased FLAIR and T2 hyperintensity in the mesial temporal lobe structures. Now, hippocampal atrophy, as seen here and here, on preoperative MR imaging is associated with a good outcome following temporal lobe epilepsy, temporal lobe surgery, sorry. Now, the other findings that we see, the secondary findings of atrophy of ipsilateral mammillary body, at times atrophy of fornix. The arterial spin labeling is an MRI sequence that helps in finding reduced perfusion. It is almost close to PET scan. Next, after MRI, the imaging modalities that are used in the surgical evaluation are, number 1 being positron emission PET scan. It utilizes radioactive isotopes linked to metabolic molecules to analyze functions. Now, in investigating temporal lobe epilepsy, PET seeks to localize regions of interictal hypermetabolism in the temporal lobe. Now, while doing a PET scan, EEG recording is important to make sure hypometabolism in one hemisphere is not secondary to an active seizure in the other lobe, leading to hypermetabolism on the other side. Now, FDG, fluorodeoxyglucose, is the most commonly used isotope. And FDG PET has a high specificity for mesial temporal lobe epilepsy. Now, mesial temporal sclerosis is also associated with hypometabolism involving other associated mesial temporal lobe structures like amygdala, entorhinal cortex. Now, it has also been shown that interictal hypometabolic regions identified during PET scan, they correlate well with the identifying the seizure focus when they are compared with depth electrode recordings. Another important point is PET does not provide any additional information if a mesial temporal sclerosis is found on MRI. Therefore, PET is typically reserved for patients in whom MRI and other preoperative tests fail to identify the seizure focus. Next in line is a SPECT scan, single photon emission computed tomography. The concept of SPECT is cerebral blood flow is basically increased in regions of the brain undergoing seizure activity, primarily because of increased metabolic rate. Now, SPECT measures local cerebral perfusion using technetium 99 molecules, and therefore injecting these traces immediately following a seizure may help localize the area of ictal onset. Now, the sensitivities of SPECT is again increased if interactive studies are used to compare the relative change in perfusion during seizure activity. Next in line is a functional MRI. Now, it is mainly used for localization of eloquent cortex, such as motor and language cortices. It can also be coupled with EEG analysis to identify ictal onset, the zone of ictal onset. And it is often used as a non-invasive alternative to the WADA test for language lateralization and localization of the cortical speech areas. And during the functional MRI, increased signal activation during language and memory tasks, ipsilateral to the ictal focus and intended area of surgical resection, they predict greater deficits following surgery. A few studies have shown that this neuropsychological assessment is important for patients with temporal lobe epilepsy because it helps us identify preoperative deficits, if any, and helps us predict postoperative outcomes. Now, a planned surgical removal of the temporal lobe and hippocampus necessitates evaluation of language and memory. Now, often patients with dominant lobe temporal lobe epilepsy, they display subtle memory deficits and also have word finding difficulties. On the opposite, patients with non-dominant temporal lobe epilepsy display viscospatial memory dysfunction. Now, patients with medically refractory epilepsy, as already laid out by Dr. Malcolm, who were defined by failure of 2 appropriate anti-epileptic medication trials, they're candidates for temporal lobectomy and amygdala hippocampectomy. Now, going to epilepsy surgery now, temporal lobe resection. It has been carried out earlier, but systemic surgical programs began only after World War II, especially after 1950s. And in the initial surgeries, hardly any mesial structures were removed. Only after 1950, the modern temporal lobectomy with its extensive mesial resection was popularized, and surgeons from all over the world began to carry out temporal lobectomies. Now, over the next 50 years, the fundamental basis has remained the same, but there have been variations in the technique. The selective amygdala hippocampectomy was initially devised by Professor Neymar, but became more popular in 1980s after Professor Yasser discovered or proposed the Transylvian approach. Now, of late, surgeons have swung back to a combined mesial and neocortical resection. Although more restricted neocortical resection is now used than the classic en-bloc operation. Now, the interventions for mesial temporal lobe epilepsy can either be resective, ablative, or neuromodulatory. Resective has been the standard temporal lobectomy, where we remove the superior, middle, and temporal gyrus for about 4 centimeters on the dominant and 5.5 on the non-dominant hemisphere. The anteromedial temporal resection has been popularized by Dr. Spencer from US. And my video next will be focusing on that. The selective amygdala hippocampectomy, as said earlier, was popularized by Neymar, and the Transylvian approach by Professor Yasser. The ablative procedures are radiofrequency thermocoagulation. And the other one is LIT. That is the laser interstitial thermotherapy, which is being popularized now in the US. And radiosurgery is also used occasionally. The neuromodulatory therapies include vagal nerve stimulation, and hippocampal DBS has also been described. Now, this is a Spencer's technique, anteromedial temporal resection, where 3.5 centimeters of the middle and inferior gyri are removed. Now, this serves as an access to opening the temporal horn and further resection of the mesial structures. Now, his theory was based on the fact that extensive studies have shown that there is no language representation in this 3.5 centimeters of middle and inferior gyri. And also, therefore, language mapping is not necessary in patients who are subjected to this surgical technique. And the visual field cuts are also smaller post-operatively. Now, the most common deficit following surgery in temporal lobe epilepsy is memory decline. Now, this was published by Professor Engel in 2003. Now, the most important point in this slide is the level of preoperative function. It has been proven beyond doubt that in patients who have at least 2 standard deviations or so below normal memory and language tend to improve with this resective surgery, and patients who have normal language and memory preoperatively, most of them have a minimal worsening post-operatively, and these patients need to be adequately counseled when they are taken up for surgery. Now, this is a classification of seizure freedom following surgery. The Engel's classification is the traditional one, but it had a few vague terminology like rare disabling seizures in surgery. It was difficult to quantify this, and therefore the International League Against Epilepsy has come with another classification which is more clear and has no doubts in it. The structures that are primarily removed in amygdala hippocampectomy are the hippocampus, amygdala, parahippocampal gyrus, and the uncus. Now, let's go into a little of operative anatomy, a few important points. Number one, this is the lateral section. And 2 points with regard to this slide is, this is the temporal horn. The temporal horn is most often projected to the middle temporal gyrus. And therefore, during surgery, when we tend to open the temporal horn, it has to be through the middle temporal gyrus. Another important point is the temporal horn never comes up to the temporal tip. It usually starts about 3 centimeters from the temporal tip. And therefore, while opening the temporal horn during temporal lobectomy, we usually open it at the posterior margin of our resection. Next is the uncus. Now, this is the cisternal, this is the view from the cisternal segment. Now, this is the parahippocampal gyrus, and there is a hook above the parahippocampal gyrus, which is the uncus. Now, the uncus has an anterior segment, a posterior segment. Both these segments meet at the apex. And the undersurface of the uncus is separated from the parahippocampal gyrus. This is called the uncal notch or the hippocampal sulcus. The importance of this anatomic landmark is the hippocampal vessels, the feeders for the hippocampus, which are divided while removing the hippocampus, they enter through the hippocampal sulcus. Another important point is, though not shown, the oculomotor nerve courses below the apex of the uncus. Now, this is a basal view, that is, we look above from below. Now, this is the uncus. This is the apex of the uncus. Now, this is the hippocampal sulcus or the uncal notch. Now, this is on the right side of the basal brain. The parahippocampal gyrus has been removed. Now, all these images have been borrowed from Roton. Now, these are the hippocampal digitations that are seen after removal of the parahippocampal gyrus. They have various names. This is the uncinate, this is the band of Giacometti, and this is the limbic. Now, this is the dentate gyrus. Now, this is the fimbria of the fornix. This is the lateral geniculate body. Now, the gap between this fimbriae and the lateral geniculate body is the choroid fissure. The choroid fissure primarily separates the fornix fimbriae from the thalamus. Now, this anteriormost point is called the inferior choroidal point. The importance of this is this is where the choroid plexus of the temporal horn starts. And this is also the landmark. The inferior choroidal point is a landmark which separates the head and the body of the hippocampus. Now, the lateral geniculate body of the thalamus is just posterior to the inferior choroidal point. And the hippocampus is so called because it resembles a seahorse. And as I said earlier, it contains the hippocampal proper, with the corn hormone is CA1 to 4, the subiculum, and the dentate gyrus. Now, this is an axial section looking down from below. Now, this is the head of the hippocampus, which is buried here. This is the body, and this is the tail. Now, here it can be appreciated. Now, this is the uncus. This is the anterior segment, the apex, and this is the posterior segment of the uncus. Now, this is the head of the hippocampus. The head of the hippocampus lies just behind the posterior segment of the uncus. Now, this is the fornix fimbriae, and I'm not sure if you can appreciate, this is the inferior choroidal point where the choroid plexus just begins. And this marks the junction between, this is the head and the body of the hippocampus. Now, this is again a lateral cross section. Now, this is the inferior choroidal point where branches of the anterior choroidal artery enter the temporal horn. And this is the inferior ventricular vein, which exits the roof of the temporal horn and eventually joins the basal venous system. Now, this is the head, body, and tail of the hippocampus. The tail of the hippocampus eventually merges into the atrium, into the calcar avis. The next important structure that we commonly remove during surgery is amygdala. In this image, one can appreciate the gray nucleus here. Now, this is the temporal horn. This is the head of the hippocampus. This is the amygdala. The amygdala lies above the head of the hippocampus. Another important point to note is this is the basal ganglia. The amygdala merges with the basal ganglia, especially the globus pallidus. I think one can see that this is pale compared to this. That is why it's called globus pallidus. And the amygdala merges with the globus pallidus. Now, during surgery, there is no clear defined boundary between the basal ganglia and the amygdala. Now, this is the optic tract. The optic tract serves as a landmark. This is the uncus. Now, this is the recess, optico-uncal recess, which serves as a landmark between amygdala. This is the ventral amygdala. This is the dorsal, which merges with the basal ganglia, globus pallidus. Now, this is another axial section. We are seeing from below upwards. Now, this is the temporal horn. This is the head of the hippocampus. And here we might be able to see that this is the amygdala. So from these two views, one can appreciate that the amygdala is located anterior and superior to the hippocampus. An optic tract is the landmark separating amygdala from globus pallidus. Now, this is anatomy of the optic radiations. The optic radiations, they form part of the roof and lateral wall of the temporal horn. And the Meyer's loop forms the anterior-most portion of the optic radiation. Now, this shows variation in the extent of the Meyer's loop. It is therefore important that when we open the temporal horn, we go as inferior as possible to avoid injury to the optic radiations. Now, coming to the vasculature, the supply. Now, the internal carotid artery, this is the A1, anterior cerebral artery. This is the M1, middle cerebral artery. This is the posterior communicating, joining with the posterior cerebral. This is the anterior choroidal artery. Now, the anterior choroidal artery enters the choroid, the temporal horn, through the inferior choroidal point. This is again lateral view. This is A1. The M.Ch goes there. This is the anterior choroidal artery, which gives a branch, the inferior choroidal artery entering the temporal horn. This is the posterior cerebral artery, which gives its branches. Now, the middle cerebral artery and the anterior choroidal artery are related to the anterior segment of the uncus, and the posterior cerebral artery is related to the posterior segment of the uncus. This is an angiogram. This is the posterior communicating artery. This is the anterior choroidal artery going, and this is probably the choroid plexus. Now, this is the posterior cerebral artery. Now, it gives branches. This is the hippocampal artery. This is the long hippocampal artery. This is the short hippocampal artery. Now, these have to be divided at surgery. Now, these are lateral posterior choroidal arteries which enter the choroidal fissure, and every attempt has to be made to preserve these arteries at surgery. Now, these hippocampal arteries, as said earlier, enter the hippocampal sulcus between the dentate gyrus above and the parahippocampal gyrus below. This is at surgery during a left hippocampectomy. This is the fimbriae. Now, this is the arachnoid that overlies the hippocampal vessels at surgery. Coming to a case presentation. This was a 28-year-old female who's been having seizures for the past 15 years, since 13 years of age, had automatism, had more automatisms, contralateral upper limb posturing with postictal aphasia. All these were pointing to mesial temporal origin with a dominant involvement because of aphasia. Was having at least 3 episodes per month, lasting a few seconds. She was on oxcarbazepine 400, 450 BD and clobazam 10 mg HS. And she had history of febrile illness, febrile convulsions, the early childhood. Neuropsychology showed a minimal drop in verbal memory. And she was evaluated with, apparently I don't have the video EEG. Now this is the MRI of the patient. As one can see, the hippocampus is hyperintense. This is T2 imaging. The temporal horn is more prominent. Also of note, one can see the temporal neocortex is also a bit smaller. The sulci is more well defined on the left side compared to right. Now she was taken up for surgery. Now at surgery, we made a small left-sided frontotemporal craniotomy, and now this is the ecology. Now in proven mesial temporal slope sclerosis, there is no need for ecology. But in this case, we had a suspicion if there was any involvement of neocortex as well. So we used ecology to see for any spikes. But apparently there were no spikes on ecology. Now we do recording from the superior, middle, and inferior temporal gyri. Now this is the 3.5 centimeters marking on the pen field. And this is to define the borders of resection. Now this is resection of the lateral neocortex. Now this is the superior temporal gyri, this is the Sylvian fissure. And in fact, a minimal portion of middle temporal gyrus has also been left in situ. The resection of the white matter. Now one important point is where to stop the neocortical resection, how deep to go. There's a landmark now, I'm not sure if we can appreciate. There's a bony landmark on the middle cranial floor. That is exactly where one needs to stop to make sure we do not go prematurely very deep into the temporal horn or mesial temporal lobe strictures. Now this is removal of the lateral neocortex. Once the lateral neocortex is open, the next important step in the surgery is opening of the temporal horn. Now here we have the fusiform gyrus. Now just following the fusiform gyrus above, we can tap the temporal horn. Now this is the temporal horn. Now this is the head of the hippocampus. Now this is removal of the uncus. Now to define the upper margin of removal of, sorry, not the uncus, amygdala, sorry. This is removal of amygdala. To define the upper margin of removal of amygdala, now this is the head of hippocampus where we have the inferior choroidal point. We need to draw a line from here, and by subpile dissection, we shall be able to see the genu of M.Ch there. Now, a line drawn from genu of M.Ch to the inferior choroidal point, and another line here. This triangle defines the extent of resection of amygdala. Another important point is, while resecting amygdala, we don't go very medially. We resort to subpile dissection because there are perforators of the optic tract underneath, and one might injure if we open the cistern there. And as said, we generally resort to a little less aggressive resection of amygdala unless there is amygdalar atrophy on MRI or the patient presents with fear in the semiology. Now this is, again, this is the hippocampus. Now when resecting hippocampus, we need to go all around the hippocampus. First, we dissect on the lateral margin of the hippocampus. Now, this is again subpile resection. I think one can appreciate the arachnoid there. This is the arachnoid. This is subpile resection. Now then we go anterior. Again, subpile resection is the most helpful technique in mesial temporal lobe surgery. Now, once that is done, now we come to the medial portion. Now, this is the fimbria of the fornix. And in classical hippocampal sclerosis, we usually get a good plane. Now, this is the midbrain, cerebral peduncle. We get a good plane between the fimbriae and the midbrain. Now, with the pen-filled dissector, I'm trying to slowly elevate the hippocampus, sclerosed hippocampus of the mesial structures. Now, once that is done, the hippocampus, we try to rotate the hippocampus from anterior to posterior using a pen-filled dissector. Now, as we rotate, we see hippocampal, as I said, the long hippocampal feeders. And we try to coagulate these feeders as close to the hippocampus as possible. The hippocampus is then removed en bloc. It is always preferable to do en bloc resection of hippocampus because it helps in better morphological or pathological classification. Once that is removed, that completes the surgery. This is the mesial temporal lobe structures that are seen. This is the posterior cerebral artery. This is the third now. Now, this is the free edge of the tentorium. This is the course of the posterior cerebral artery. This is the postoperative, typical postoperative scan we see after amygdala hippocampectomy, showing the resection cavity extending up to the suprasylvian cistern or the ambient cistern. The patient, but in generally, another important point is in these patients, we do not immediately taper them off these drugs. We usually maintain these patients on the same dosage. It is generally advisable to wean them off 6 months in children and after 1 year in adults. For her, we were able to wean her off after 1 year and has been seizure free for the past 1 year. Thank you.
We will have it was an excellent presentation of both the speakers. The Rohit sir has given a demonstration and the Malcolm sir also has given the excellent.
Thank you very much, Dr. Rajesh Babu. Thanks a lot for the speakers, Dr. Malcolm Jeyaraj, who is the guest speaker from the neurologist. And we thank Dr. Rohit, who is one of our member and active member of our TANs. And both were very nice educative section. Actually, we learned a lot.